the badness out.
So, good morning to those joining us remotely. We're doing Dermpath session, and focus today is on pilar and sebaceous neoplasms. So, Shane, you want to lead us off here with what you see?
Yeah, I see a pink fibrous orb.
A pink fibrous orb that resembles a massive reduplication of the normal fiber sheath.
Okay. And they're islands of tumor, but there are no hair follicles, so like a fibrofolliculoma. Oh.
So a fibrofolliculoma would be if there are no hair fibers, if there are, if you see trichohyalin or hair fibers anywhere, then it would be a trichofolliculoma. So trichofolliculoma or fibrofolliculoma, both of them are mama and babies, central follicle, pilar stroma, and either just fingers of basaloid epithelium or more differentiated towards actual hair follicles. The problem is that trichofolliculomas go through catagen and just like any other hair, and so you can have periods of time where the trichofolliculoma resembles a fibrofolliculoma. This one's somewhere in between. What you need to do is just raise the possibility of associated syndrome. Are trichofolliculomas particularly associated with syndromes? Or are fibrofolliculomas more associated with syndromes? The second one, shockingly enough. Okay, so if it's the fibrofolliculoma, what syndrome might it be associated with? Birt-Hogg-Dubé. And how will patients with Birt-Hogg-Dubé present?
Well, they may have multiple of these. They are at higher risk of cancer as well.
And what type of cancer?
You have chromophobe renal carcinoma. They may have spontaneous hemothoraces. They also have the renal.
So the renal oncocytomas. Oncocytomas are these granular red tumors, and renal oncocytoma is quite rare, so you have a rare cancer running in families, which is how they identified the syndrome, right? How do they present usually in adolescence, though, a Birt-Hogg-Dubé patient?
Sure.
Anyone want to jump in?
Mm-hmm.
Spontaneous pneumothorax. So, on the basketball court, sudden chest pain, etc., spontaneous history of spontaneous pneumothorax, bumpy face, renal cancer, oncocytoma. So, part of the famous bumpy face differential, which we all know and love. Okay. How about this one, Kendall? What do you think?
Okay, so it looks kind of jagged. We have like basaloid cells kind of sprinkled throughout.
And you have kind of a central dilated infundibular space, right? And then when you
so is that
adjacent, is this just primitive basal epithelium, or is it more differentiated than that?
I think it's a little bit more differentiated than that.
And in fact, you have trichohyalin, which is the red stuff, right? So you have fully formed follicles.
Yes.
And periodically here you see hair shafts.
So are we thinking like trichofolliculoma,
Like
the mom and baby thing?
Like mama and her babies. So you have fingers of fully formed follicles forming follicular fibers, right? Which would be the folliculoma.
Like in Dr. Seuss.
So it's a mama and her babies, and the babies are fingers of fully formed follicles forming follicular fibers in a folliculoma, right? And then the stroma unlike basal cell stroma, is very fibroblast rich, and there is no retraction space between the tumor islands and the stroma. The only clefts are within the stroma itself. Right? So that all goes with a benign pilar tumor, in this case mama and her babies, so trichofolliculoma. Okay, Dan.
So this appears to have a sebaceous differentiation.
Sebaceous differentiation, in fact, anything blue, a blue lobular tumor with ducts is likely to be sebaceous. Red lobular tumor with ducts is likely to be acrospiroma, and blue lobular tumor with ducts is likely to be sebaceous at scan. So it's a blue tumor with ducts, so you are correct, probably sebaceous. So then the question is, good sebaceous, not so good sebaceous?
Well, that's the question. I still think it's good. I think it's, I don't think it's a hyperplasia. I think it's more
So if it's a little more than a hyperplasia, where is it likely to fall?
This one can't change. It's the one that can't.
Okay.
It's either
Wait, what am I looking for?
sebaceous adenoma versus sebaceous. I think it's sebaceous adenoma.
Yeah, and so at that point, are there any syndromal associations?
Mortuary.
So Muratori, tell me about Muratori. And that's why, you know, the adnexal tumors, it's all well and good that you have names. It's, our residents used to joke that there were just 3 wheels that you would spin. One would say things like trichofibro, and the other would be and you just spin the wheels and the names would be made up, right? The identifying which tumor it is among the benign ones, the reason it's important is the associated syndromes. So there are systemic complications, which is why they're important to know, which is also why they would be testable, right? So, okay, so tell me about Muratori.
Sorry, I don't know.
Okay, anyone want to jump in?
It's a microsatellite instability.
Microsatellite instability, so it's a subtype of what other syndrome?
Lynch syndrome.
Lynch, so it's a subtype of Lynch. And whereas Lynch, the microsatellite instability gives rise to what in the patients?
Like gastrointestinal.
Hereditary non-polyposis gut carcinoma. So most familial gut carcinoma is associated with polyposis, but there's also familial non-polyposis gut carcinoma, which is Lynch syndrome, and a major subtype of Lynch is Muratori, which presents again with a lumpy, bumpy face. And the sebaceous adenomas can be on the face. They can also be anywhere else on the bodies.
That is the one that stained like MSH1.
So correct. So MLH, MSH, PMS2. There are 4 microsatellite instability markers. MSH6 alone deficiency is less likely to be associated with the syndrome. They function as dimers, so MSH6 and MSH2 are together. We usually look for loss of MSH2 because isolated loss of MSH6 usually sends you on a wild goose chase that doesn't mean anything. And then the LMH and the PMS are linked together, so we usually look just at MLH1 and MSH2 in skin. Conventionally, I know you tend to look at all 4 in gut, but in skin, loss of markers means a little different, the data show. And so those 2 are likely to give you a higher yield for the syndrome. And then the next step is to look at the family. Do you have a family history of gut cancer? Do you have other sebaceous cancers? Do you have what other skin tumor is multiple in these patients? keratoacanthoma, and the KAs are usually very, very aggressive. So your average Muratori family, you will have someone who has lost eyelids and noses to aggressive keratoacanthomas. One of the families that we followed, she had survived multiple cancers associated with her syndrome, including gut cancer on more than one occasion, had been through chemo on more than one occasion. When I met her, she was about to lose her nose, both lids, and both ears to aggressive keratoacanthomas, and she asked, I've been on chemo before, all my KAs melted away. The chemo wasn't as bad as what I'm looking at with the surgery. How about if we just do the chemo again? And so her oncologist, who knew her very well, started her back on systemic 5-FU. All her keratoacanthomas went away. She saved her lids, her nose, and her ears, which is a better outcome. Since then, we now have capecitabine, which is oral 5-FU, and for many of these people, that is exactly what you want to do to get rid of the keratoacanthomas without disfiguring surgery. Okay, so this one is a little faded. The first thing you have to do is look at how the tumor compares to the surface epidermis. Everything's a little faded. So we're going to look a little higher, see can you make out clear-cut differentiation of some sort.
I mean, it looks sort of spacious in this area.
Looks kind of sebaceous. And if, you know, it sure looks like sebaceous differentiation, but if you want to confirm it, any stains that you might use?
Yeah.
So EMA and EMA stains simple epithelium. The way it stains sebaceous different is it outlines every vacuole, which is something you don't see in other simple epithelia. So that pattern, that vacuolar pattern of EMA staining is very characteristic. Other things that you can do androgen receptor. There is also just a paper in this month's Journal of Cutaneous Pathology on using nuclear factor 13A staining in sebaceous neoplasms. So, you know, various ways to skin a cat. So non-cat friendly expression, but there are different ways to diagnose the tumor. Okay.
All right.
So Tiffany, basal next case, right?
Not in this chapter.
Not in this chapter. And the problem is when the slide comes across your scope, it doesn't have the chapter emblazoned on it. So
That's right.
okay, go ahead.
So you've already given me a clue that looks kind of like a basal cell. If I had to pick the basal cell in my differential, it would probably be like infundibular cystic, kind of.
So if it were a basal cell, it would be infundibular cystic type.
But it's not.
What if it's not? So the question is it a basal cell? Is it not a basal cell?
So I don't think it's a basal cell.
Okay, what suggests that it's not a basal cell?
The stroma is not very myxoid looking.
Yeah, the stroma is not really myxoid at all. In fact, it's fibrous with many fibroblasts. The fibroblasts run in a concentric pattern. Is there any clefting between tumor island and stroma, or is there merely clefting within the stroma itself?
Within the stroma itself.
And so that would go with
Basaloid follicular hamartoma.
Basaloid follicular hamartoma is actually the one that has a myxoid.
Oh, that one
stroma.
has a myxoid?
Yeah.
Oh, okay.
That's the one that is actually a dead ringer for infundibular cystic BCC.
Oh, do we?
Just that it's familial, the patient has hundreds, so does his dad, so does his uncle, and none of them ever behave like basal.
Gotcha. So is this more like like one of those, I don't see any, do you see papillary meningeal back there?
They're in there. They're just kind of weeny.
So like a trichoblastoma.
Yeah, and the well-differentiated superficial type of trichoblastoma is called a trichoep.
Okay.
It's a trichoepithelioma. So most things that are superficial in the dermis and look like a basal but have clearly pilar stroma are going to be trichoepithelioma.
Okay.
Trichoblastoma is kind of the rubric to which trichoeps belong, but we tend to use that term for the deep soft tissue tumors. So it's something that is either the world's biggest metastatic basal cell in the deep sub-Q, or it's just a benign pilar tumor, right? And the stroma tells you it's a benign pilar tumor. That's where we usually use the term trichoblastoma. Okay,
So,
David.
some basaloid islands down in the dermis. Stroma is again kind of fibrous. It's kind of concentric fibrous stroma.
So concentric fibroblast-rich stroma, is there any retraction space?
No.
Not between tumor islands and stroma, but there is clefting within the stroma. And then you have these aggregates of plump mesenchymal cells looking very similar to the body which sits in the mesenchymal body which sits in the papilla. So what would you call that?
Papillary mesenchymal
The
body.
papillary mesenchymal body, because it looks just like the plump stromal cells that sit in the papilla of the hair follicle. Okay, so what would this be?
Trichoblastoma.
Yeah, and it's a superficial variant, so you'd probably call it a trichoep. Now, some of the islands look different. Some of the islands have just a cell or two that's basaloid at the periphery, and then the rest is lymphocytes and histiocytes.
Kind of adamantinoid or lymph adenoma.
So lymph adenoma, so there are portions of this that are trichoep, about 99% of it is trichoep, but then there are little bits of it that are turning into a cutaneous lymph adenoma. The other name for that is an adamantinoid trichoblastoma, because that's easier to say. So important just to recognize these are all kind of variants on the same thing, right? They're all variants of trichoblastoma. The superficial, well-differentiated ones are trichoeps. The lymphadenoma is a variant of that, where all that's left is the peripheral row or two of basal cells, and then the rest is kind of clear space with lymphs and histiocytes. Well done, David. Okay. So now for something completely different, what do you see? Another trichoepithelioma. You have a central infundibular-like space. You have fingers of basaloid islands. You have no tumor retraction, but you do have lots of clefting within a fibroblast-rich concentric stroma. And you've got, not the world's best, but you got some papillary mesenchymal bodies, so it's a trichoep. Very good. Are there any syndromes associated with multiple trichoepitheliomas?
Brooks-Spiegler?
So Brooks-Spiegler is multiple trichoeps associated with?
Let's see. It's not cylindroma.
It's
Cylindroma? Okay.
So I guess if you were playing Jeopardy,
For a
because
thousand.
you phrase it as a question,
What is
you
cylindroma
might-
and trichoep?
so it is cylindroma and trichoepithelioma. Very good. Independently described by Dr. Rasmussen, so it's either Rasmussen syndrome or Brooks-Spiegler. They're the same. And anything else associated with So Rombo syndrome is also associated. So there are, a few others that can be associated. Okay, how about this one, Blake? What do you see?
So thick eosinophilic corneum.
So if that's the surface, is this an endophytic or exophytic lesion?
I'd say endophytic.
An endophytic lesion. And is it more red or more blue?
I'd say red.
It's more red, and it has a infundibulum-like opening, and then little fat red fingers hanging off of that.
So I like dilated pore of Weiner versus pilar sheath acanthoma.
Exactly, and those are variants of the same thing. So it depends how fat your fingers are, right? If the fingers are really fat, it's a pilar sheath acanthoma, and if the fingers are skinnier, they've been on a diet, then it's a pore of Weiner. You missed your opportunity to call it a pore of Weiner. You need to whine. Actually, Dr. Weiner was a very accomplished man, so that's not a very nice thing to do. Dr. Weiner was one of the original founders of the Dermpath Society. So, skinny fingers. This one has some fat fingers. So if they're more like that, you'd call it a pilar sheath acanthoma. If it's more like this, you'd call it a pore of Weiner. It looks just like the punctum of an EIC. And in fact, if you...
Nicole.
And let's see, Nicole, we're logged in as you, so you got to get in there.
I thought Justin fixed it. I was watching.
You can't fix it.
You can't change the log off. You can only change the screen.
Sounds like a person.
So my wife read in the paper there was an older woman who was always forgetting her password, so she made her, as her password, she chose the word incorrect. So if she'd ever type it in wrong, then it comes up and says, your password is incorrect, right? So that is in fact a pore of Weiner, looks just like the punctum of an EIC. So if on plane of section you're looking just at the punctum of an EIC, it looks just like a pore of Weiner or pilar sheath acanthoma. Pore of Weiner and pilar sheath acanthoma have no underlying cyst. They just consist of the punctum. And they've been described as, the punctum of an EIC in search of its cyst. Right. Okay. So, Brian, what do you see?
So big dermal nodule, lots of cystic spaces. Looks like there's some serum and almost necrosis in some of the areas. I'm trying to find shadow cells because I think about a pilomatricoma.
So the architecture resembles a pilomatricoma, but instead of keratinizing with shadow cells, it has a similar architecture but has abrupt homogeneous keratinization. So what has an outline like a pilomatricoma but a different type of keratinization?
This is like rolls and scrolls of proliferating pilar.
Like a proliferating pilar cyst. So that, remember in the chapter we do not only the entities but the differential for those entities. So proliferating pilar cyst looks like a redder version of a pilomatricoma. Pilomatricoma is rolls and scrolls forming a nodule, but it's blue. And proliferating pilar looks the same except it's red. The one keratinizes with shadow cells, the other with abrupt keratinization. So you will never be fooled. Very well done. Beautiful and well done, sir. Okay. How about this guy?
Okay, so I've got some, what I think should be basaloid-looking islands. This slide is pretty
so it's a
faded.
basal cell, right?
Well, we're not in the right chapter for that.
Okay, go ahead. So so we cannot fool Rachel. Go ahead.
Well, let's see. Our other basal cell mimicker looked like an infundibulous cystic basal cell, which this doesn't really.
So an infundibulous cystic BCC still has a very myxoid stroma. Here the stroma is more fibroblast rich, concentric with clefting within the stroma, but no retraction from tumor island. So this would be a.
I'm thinking just it looks more like some sort of trichoepithelioma.
Like a trichoepithelioma. Very good. Well done. Okay, how about this one?
Let's see. So it's more of like a, I don't know, the terminus looks kind of busy, but there's also like a central infundibulum type.
Yeah, so there's like a central infundibular-like space, and then hanging off it are the things more blue or more red?
More red.
More red. And is there any underlying associated cysts that you can see?
I do not.
So what do you want to call it?
Dilated porovoiner.
Porovoiner. Very good.
So it looks like we're getting the majority of just like an acanthotic looking epidermis. The cells themselves look a little bit cleared out, maybe glycogenated.
So they're glycogenated. Does it palisade or not palisade?
Yes, it pulsates.
It palisades. It's made of clear cells
And then thickened basement
and
membrane.
a thickened basement membrane zone. So watch out. It's tricky. What is it?
Tricholoma.
A trichilomoma. So trichilomoma looks like the outer root sheath of the hair follicle. So it has peripheral palisading. It's surrounded by a thick, glassy basement membrane zone. And the cells themselves are glycogenated, just like the outer root sheath. Now, if multiple, is it associated with any kind of syndrome?
Yes, sir, Cowden.
Cowden's. So tell me about Cowden's.
You see multiple hamartomas, GI tract, then you see pulmonary hamartomas.
So you have hamartomas in the GI tract, and did you mention the familial cancers that go with it?
I did not.
Would that be important to the patient?
Yes, sir, I believe it would
Okay, and so what particular cancers go with Cowden's?
Not GI malignancies.
Not GI, typically. The gut. So gut polyps are very common in Cowden's, but they're benign.
I think it's maybe endometrial or GU type.
Or breast,
Or breast.
as the most common. And is it a nice low-grade tumor like you get in Lynch?
It's probably a nasty tumor.
It is a horrible tumor. So in the days before HIPAA, Cowden syndrome is not named for a physician named Cowden. It's named for Rachel Cowden, who died pretty horribly of widespread metastatic breast cancer, as did her mother, as did her aunts, as did every female in her family in an autosomal dominant family pattern. And she had a lumpy, bumpy face, but whereas most of the lumpy, bumpy face syndromes, the bumps are smooth, her bumps were warty looking. So it looked very different. And doctors like Peyton Weary suggested that this was probably some sort of familial syndrome with a little benign adnexal tumor as a marker for that syndrome. And so it's named after her, the patient. So Cowden syndrome, very, very aggressive, metastasizing. So your chances are worse than having BRCA. And so Cowden syndrome, very aggressive. And as with BRCA, the treatment is bilateral prophylactic mastectomy in those families. And when that recommendation first came out, we thought, boy, talking young women into that, it's not hard because they saw their mother die, they saw their aunts die. So the families are hit hard. And so there are other. Thyroid is the second most common. Thyroid is actually the most common in males with Cowden's. And then in females, the aggressive metastasizing bilateral breast carcinoma. So anytime you see trichomonas, you have to raise that possibility. Okay.
This looks like a pilomatricoma. There's some ghost cells and some bone formation, very well-defined basaloid islands.
Yeah, so you have well-defined basaloid islands. This particular one does not have a rolls and scroll pattern. Instead, it's smaller nodules, but they clearly keratinize into ghost cells just like the hair matrix. So if it keratinizes like the matrix of the pylo, then we would call it a pilomatricoma, right? And multiple pilomatricomas, are they associated with syndromes?
The beta-catenin, myotonic dystrophy.
So myotonic dystrophy. So myotonic dystrophy, the myotonic part is you shake my hand and you can't let go. That's the myotonic part of myotonic dystrophy in those families. And then you noted that ossification can occur in these, and if you ever see that, then you can say that you have a bona fide example of pilomatricoma, right?
Wow.
The worse they are, the better I like them. Okay. So, Nicole.
So you have islands of basaloid cells, but they look like they only have kind of like an outer layer or two.
And what's the center composed of?
Lymphocytes and histiocytes.
Okay, what would you call such a tumor?
I call it a lymph adenoma.
And curiously enough, it has a fibroblast-rich concentric stroma with clefting in the stroma like any other trichoblastoma, right?
Mm-hmm.
So this one is called a lymph adenoma, or the easier name?
The adamantinoid trichoepithelium.
Or trichoblastoma, yeah, exactly. So adamantinoid trichoblastoma, because they look a little like a dental adamantinoma, or lymphadenoma, which is by far the more commonly used name. Good.
So we see another fibrous orb.
Another fibrous orb.
There are,
And you have to put the emphasis on the B. Orb. Yes.
there are islands of tumor inside that. Looks like they're associated with like sebaceous glands.
So they have sebaceous glands, and they all radiate centrally towards Big Mama, right? And do they have fully formed follicular fibers?
They look like they do.
So what would it be? A trichofolliculoma. And this one, you don't see so much basilar type epithelium. You're not really seeing those parts of it. You're seeing more the infundibular portions, but because you have fully formed hairs going in centrally, you know it's a trichofolliculoma, not just a fibrofolliculoma. So this one would or wouldn't likely be Birt-Hogg-Dubé associated?
Would not.
Would not, correct, which would be important information for the family. And clinically, these present as a bump with a tuft of hair coming out of it, right?
That's a tough one, Dr. Elston.
That's like right exactly where I was at that level. You just made my day. Okay, how about this one?
So I'm seeing lot of sebaceous glands in the dermis. Dermis looks all right besides that. Kind of some downward extension of the reedy ridges.
Yeah, so just sebaceous glands, and then the reedy are a little accentuated. It's maybe just a little lumpy bumpy on the surface.
Mm-hmm.
So what might you think of?
Maybe like a Nevis Sebaceous?
Maybe like a Nevis Sebaceous. And Nevis Sebaceous, is that associated with anything?
Yes.
Okay, good answer. What might it be associated with?
Pass.
Okay. So when solitary, it's usually just a hairless patch. It's kind of linear, kind of like a Blaschko segment. And at puberty, it becomes cerebriform, bumpy, which is usually when they present. And they develop lots of secondary adnexal tumors in them, usually trichoblastomas. When they are systematized, so when you have multiple Blaschko segments associated, it's pretty horrible. Most of the epidermal nevus syndromes, when they are widespread, it's full thickness, everything that came from that Blaschko segment. So if it goes, when it's systematized and it goes over your scalp, you have seizures, you have bits of your brain that are missing or malformed. If it goes through an eye, you're missing that eye. If it goes through your jaw, you're missing teeth. If it goes through your hand, you're missing fingers. It tends to be a lethal gene to the deeper tissue. So a lot of those syndromes are more represented in girls, not particularly the multiple Nevis Sebaceous syndrome, but a lot of those sorts of linear Blaschkoid things are girls who survive by lionization in an X-linked dominant. If the male had it, it would be probably lethal. But the girls have lots of problems because half of their tissue got hit by the gene and is, severely hit with lots of essential things missing.
Do you exhaust them if it's like one single solitary?
Yeah, exactly. That's what we normally do because there is some risk of the secondary neoplasms occurring. But the secondary neoplasms are almost exclusively benign. Trichoblastoma and SPAPs, Syringocystadenomatous papilliferum, are the most common. Okay, how about this one?
So, large islands of basaloid cells.
Large islands of basaloid cells. Do they palisade nicely like a basal cell?
Not particularly.
Not particularly. And is your stroma a basal cell stroma?
No, it's not. There's no retraction. It's not fibromyxoid.
No, it's not fibromyxoid. Instead, it's fibroblast-rich, concentric, more like a pilar tumor.
So it's probably a trichoblastoma. It just has like this odd separation, and I don't know if that's just an artifact from the slide.
Yeah, so trichoblastoma. And then this one's pretty big. So the question would be, is this a benign trichoblastoma or a malignant trichoblastoma? When you start getting areas of necrosis and an invasive growth pattern, and it becomes hypercellular, the cells become often small and very packed, then it can behave malignant. And a malignant trichoblastoma, does that behave just like a basal cell?
I would assume it's more aggressive than a basal cell.
Most of the malignant adnexal tumors are pretty nasty.
Is that's artifact or is that the necrosis?
There's some necrosis and some artifacts. So kind of whichever you want that's there.
Okay, cool.
Okay, Dan, how about this?
Looks like a big donut-shaped appearance of trichoblastoma.
Yeah, so donuts. Sometimes they're paired like eyeglasses. So red donuts in the dermis, sometimes paired as eyeglasses. Differentiates towards the infundibulum of the follicle, and that is the trichoadenoma. Very good. Let's Okay. I'm going to make sure in the time we have left we're hitting things pretty well. Okay. How about that, James? Let's get the dust off there. Sorry.
Kind of nondescript bump there from the milk tube.
A kind of nondescript bump, so you can reassure the patient just to ignore it, right?
I mean, that looks like at the edge there, trichomoma to me.
So it looks a little bit like a trichomoma with island hanging downward, that it's glycogenated like the outer root sheath with a peripheral palisade and a little bit of a thick glassy basement membrane zone. So would the presence of multiple tricholemomas mean anything to a patient?
Yes.
Good answer, sir. Would you care to elaborate?
The other trichomoma.
This makes friends. Cowdens, the cows are moving.
So tricholemomas go with cowdens. Okay. So tricholemomas with cowdens, very good. And cowdens, is that a cute syndrome to have?
Most syndromes are not cute to have.
Most syndromes are not cute to have. So the families are hit pretty hard, mainly with breast cancer, thyroid cancer, but also goiter, also benign gut polyps, and cobblestone mucosa. I'm sorry, what?
You can think of moo glands. That's one way to remember it.
Well, you think of the cow, and it's got like the hen neck, and then the udders.
There's a lot of cows.
And a cowbell, which is the goiter. Okay.
I remember some things somehow.
Okay, so how about this one, Tiffany? What do you think?
I think I'm seeing some. So we have like a somewhat dilated follicle, but there are little hairs coming off.
Yeah, so like a central infundibular mama.
Yeah. Okay.
And lots of little babies heading into mama. So what would you call this?
A trichofolliculoma.
A trichofolliculoma. Bad, horrible syndrome or not bad, horrible syndrome?
Not bad.
Not bad, horrible syndrome. So that's kind of nice, right?
It's a large dermal nodule.
Large dermal nodule.
I think the architecture of like a pilomatricoma to me, but...
So is it all differentiating towards the matrix?
No, there's
or is there a lot of infundibular differentiation?
A lot of infundibular differentiation.
And matrix differentiation, and inner root sheath differentiation.
It's kind of a mixed.
It's kind of cystic, and it's differentiating towards every portion of the follicle. So what would you call a cystic panfolliculoma?
Panfollicular cells?
Cystic panfolliculoma. Right. So there are epidermal cystic panfolliculoma, which is a benign cystic tumor that differentiates towards every portion of the hair follicle. So cystic panfolliculoma. And are these syndrome associated?
I'm not
Fortunately,
sure.
they are not. So cystic panfolliculoma, very nice diagnosis to make. Okay, how about this one?
So I have, she have a little bluish proliferation.
Okay, and they have trichohyalin.
Trichohyalin. So.
And they all enter into a central mama.
So trichofolliculoma.
So it's a trichofolliculoma. So we've seen examples of kind of more reddish, better differentiated. This is a little less well differentiated, but still has all elements of the hair follicle, to include inner root sheath and hair fibers, and they all radiate into central mama. So you can have ones that are a little bluish and a little less well differentiated. You can have some that are a little more well differentiated. How about this one?
I would think like pilomatricoma.
So pilomatricoma trichomas tend to be kind of blue, right?
Mm-hmm.
These you have fully formed follicles with an inner root sheath. You can see trichohyalin. They're all heading inward towards mama.
Trichofolliculoma.
So it's a trichofolliculoma. A little bit different look again. So we've seen multiple looks of a trichofolliculoma. A common benign tumor that has a wide spectrum of appearance. Would that be something maybe that would test well?
So the difference between that and pilar sheath acanthoma is just that it has like the hair.
So pilar sheath acanthoma just has red epithelium, no blue epithelium, no inferior portion of the follicle, so no hair fibers, no trichohyalin. It differentiates only towards the infundibular portions. But they all have in common the central infundibular-like cystic structure with things radiating into it. The question is, are they red? Are they blue? Do they make follicles? Do they not make follicles? And then the importance of putting a name to it is there an associated syndrome? Is there not an associated syndrome? Is it nasty? Is it not nasty? Do we take off your breast? Do we look at your gut? What do we do? Okay, how about this one?
Thinking about a tricholemoma.
A tricholemoma. So a tricholemoma would hang off of the epidermis, would have clear glycogenated cells, peripheral palisading, surrounded by a glassy basement membrane zone that usually even at scan you can see as like a pale zone adjacent to that peripheral palisade. And so tricholemomas, are they associated with any kind of nasty syndrome when multiple?
Think Cowden's.
Think Cowden's for the tricholemoma, if that helps you. Okay.
Alright, so once again, I've got islands of blue cells and
islands of blue cells in a fibroblast-rich stroma that is concentric and is clefting within the stroma.
Yes.
What might this be?
This is a trichoepithelioma.
A trichoepithelioma. Syndrome associated?
It's something Spiegler.
Brooks Spiegler. So if you have to have a syndrome, that's not such a bad one to have. Although the patients hate it because their entire scalp becomes a mass, a turban-like mass of red tumors, which are the cylindromas. So you're not going to die of cancer, but cylindroma, I mean, Brooks Spiegler, the patients can be kind of unhappy with the scalp involvement. Many of them, though, just have the facial involvement, tends to be warty or smooth, lumpy, bumpy face. The warty one is Cowden's.
Yeah,
the others
so
are smooth and shiny, and tends to be the melolabial folds, whereas Cowden's is often more peripheral. Cowden's loves the ears. Most of the lumpy, bumpy face syndromes like either the nose or the melolabial folds. The Berthog-Dubé loves the nose and cheeks, kind of spares the crease. Brooks Spiegler loves the crease, the melolabial fold. Let's see, somewhere here we should have tissue. There we go. So what's that?
Looks similar to the last one.
Yeah, in fact, it's the same slide. So that is a epithelioma. Okay, how about this?
Sebaceous differentiation.
Yep. And you correctly assume that did not count as your term.
Yeah. These look like well differentiated sebaceous ones. Maybe
Yep.
like sebaceous hyperplasia.
Okay. So, like sebaceous hyperplasia, because this looks like a solitary bump, and if linear, if a linear blastoid segment, then more like a Nevis sebaceous. But when just a solitary bump, often with a central dell, then it would be just a sebaceous hyperplasia. Okay. How about... There we go. Better. Sorry.
Looks like you've got some lumpy, bumpy skin.
Lumpy, bumpy skin.
Get some sebaceous glands pretty high up.
And you got some sebaceous glands pretty high up, so you're thinking?
Nevis Sebaceous.
Nevis Sebaceous. So out at the periphery, you can see this is scalp. When you go to the center, there is no hair, right? So they are broad, they are bald, they are bumpy, they are bubbly. So broad, bald, bumpy, bubbly is Nevis Sebaceous of Yada-san. When they are prepubertal, they are broad, they are bald, but they're not bumpy and they're not bubbly yet. Okay, so prepubertal is broad and bald, but not bumpy and bubbly. At puberty, they become bumpy and bubbly. The bubbles are both the sebaceous elements and also the soap bubble-like apocrine glands.
Looks like another pilomatricoma.
Looks like another pilomatricoma. And if there were focal ossification,
It's bona fide.
it is a bona fide example of a pilomatricoma. Very good.
So, basaloid cells in the dermis. And they look like pretty well circumscribed islands. I would like to go closer.
And you may not.
No, you may not. From here, I'd probably call it a epithelioma trichoblastoma.
Exactly. I mean, it looks, the stroma with clefting in the stroma, fibroblastoid stroma, basaloid islands, peripheral palisade, looks like a trichoblastoma. If it's superficial and well differentiated, it's trichoep. If it's deeper, more nodular, it's trichoblastoma. Just kind of generic. This one's, lots of people would probably call this trichoblastoma. This one is pigmented. Remember, all the adnexal tumors can be pigmented.
Is that retraction up there?
So the question is that retraction or is that artifact? So you look a little closer. Is the cleft within the tumor island or between the tumor island and the stroma? So is there epithelium hanging on to that fibroblastic stroma? So then it's not a true cleft.
Gotcha.
Right. Okay, so this was taken out from the deep subcutaneous tissue. You can see the skin, you can see the subcu. This is a purely subcutaneous tumor. Would you call this more like small puny or big large?
Quite large.
Quite large. So this large subcutaneous tumor, do you see any retraction space around the tumor islands, or is there only clefting within the stroma?
Only within the stroma.
And it's fibroblast rich with papillary mesenchymal bodies, so what would you call this very large subcutaneous tumor? A trichoblastoma. So when trichoblastomas were described, they were described as these deep things, whereas the trichoeps were the superficial things. But they're kind of variants of the same.
So we have these kind of dilated cysty-looking structures.
So like red donuts.
Or like Cheerios, I suppose. I would say trichoadenoma.
I'll get that in just a second. So like a trichoadenoma. Very well done.
Like donuts with shredded wheat, and then it's like a breakfast.
Yes, exactly. Donuts, like a very carby breakfast. Okay, let's do this one. Trichomoma, and what do you call them when they have this sclerotic stroma centrally? So that they are desmoplastic.
Desmoplastic trichoep.
A desmoplastic trichomoma.
Oh.
There are desmoplastic trichoeps and there are desmoplastic
Trichomomas,
trichomomas. And they look different. So desmoplastic trichomoma is usually solitary trichomoma, usually not Cowton's associated. There's been a central folliculitis that gives rise to these little infiltrative looking islands. A superficial shave is almost invariably called invasive squamous cell carcinoma. You can see how a superficial shave through this would be called invasive squamous cell carcinoma, right? But the excision shows a completely benign adnexal tumor with a smooth rim, clear cells, basaloid, or usually some peripheral palisading, thick glassy basement membrane zone. The hint is when you have something that looks kind of like an invasive squame, but then you see glycogenated epithelium and a thick basement membrane zone at the edge. Remember, it may just be a superficial shave of a desmoplastic trichomoma. Okay, and I think we are at the hour, so we're going to stop right there. One thing we didn't have was we didn't look at a DTE, but you looked at DTE in the earlier portion of this morning's session, right? Okay, very good. And for those online, we will see you next time.
Where's your appointment?